Welcome to episode 8 of the Expert Interview series. This one was such a banger, I've had to split it up into 2 parts. So in part 1, our expert panel discussed the why, how and when of pacing, what activity management actually involves, and exactly why it's the #1 management strategy for those suffering with long COVID, or ME/CFS. Get it wrong at your peril, but get it right, and you give yourself the best possible chance of recovery. I hope you find it useful. So thank you for joining us, everybody. First of all, I'd just like if we could get a sort of a short introduction from each of you, just telling us a little bit about your backgrounds. And Darren, if you want to start us off, that would be wonderful.
Hello, thank you for having me. My name is Darren Brown. I'm a cisgendered gay white man of mixed English and Irish heritage. I live in London in the UK. I'm a clinical academic physiotherapist. I work in the NHS, and I'm also a person living with long COVID. And I'm one of the co-founders of Long COVID Physio.
Incredibly concise. Well done. Sue.
Hi, welcome to everybody. My name's Sue. I'm an occupational therapist, and I've worked for over 30 years with people with a condition called myalgic encephalomyelitis or myopathy, depending which one you want to call it, also known as chronic fatigue syndrome. I'm co-author of the book Fighting Fatigue, which is a self-help manual on fatigue, and I'm also a national trainer for the Royal College of Occupational Therapists on fatigue. And for about the last year, in addition to our caseload that we see with ME/CFS, we've also been seeing people with long COVID.
Thank you. Ruth.
Hi, my name's Ruth. I'm a respiratory physiotherapist. I've been working in this field for 25 years now. I currently work in private practice in London, but I've been back in the Brompton Hospital in Northwick Park during the pandemics. I've been treating mostly long COVID in my clinics since June, I think was the first patient that we saw, and continuing to see them every day.
Gosh, thank you. And Todd.
Hi, everyone. My name is Todd. I'm professor and vice chair with the Department of Physical Therapy at University of the Pacific, which is in Stockton, California, east of the San Francisco Bay Area. We can't see the pretty bridges that everyone knows. And I've been involved in research and clinical practice in myalgic encephalomyelitis for the past 15 years. And then most recently have engaged in some scholarship and clinical practice surrounding long COVID. Thanks for having me.
Thank you for being here, all of you. I'm going to hand over to Asad.
So Darren, I was just going to kick off with you actually, because being a physiotherapist and being a long COVID patient with the long COVID phenotype, which includes fatigue and PEM, could you just tell me what it's been like for you?
Yeah, so in case anyone is listening and don't know what that abbreviation stands for, so post-exertional malaise, but can also be termed post-exertional symptom exacerbation. So yeah, as a physiotherapist, kind of our bread and butter is often about encouraging people to move more for the health and well-being related benefits of so. And that's actually been a particular challenge, not just for me, and also my peers that are also physiotherapists living with long COVID, but I think globally, most people living with long COVID, because most people want to get back to their normal lives and want to just crack on. So I think that's been a particular challenge, but I know that for me personally, it also was a challenge in terms of my background, my training, and my thoughts and beliefs about what was traditional models of rehabilitation. Because when I was recovering from acute coronavirus, I did what every good physio thinks they should do, which is I tried to move more, and I tried to gradually increase the amount of physical activity I was doing to combat the fatigue that I was experiencing. And it was soon that I realized that I did indeed have post-exertional symptom exacerbation, and I ended up in a crash because of it.
Can I ask where you are at now in terms of your recovery, Darren?
Yeah, I'm actually at 16 months after acute coronavirus. I've had 2 crashes. I've also had 2 vaccines. And where I sit here right now, I'm doing pretty well. I'm actually now able to work full time. I have done for the last month. I'm also back on the on-call rotas, working back in intensive care at the weekends. I'm probably about 85% as a guesstimate back to full recovery. I'm not back to normal. I still have some symptoms and impairments. I still have some activity limitations and also some social participation restrictions. So I'm really using a model of disability there. So basically, I still experience some disability in day-to-day life, but I'm able to do most of my usual functioning.
That's really good news. Very, very glad to hear it.
So thank you very much for that, Darren. And I guess there's hope for us as well. We've both been told to pace, so both Jez and I. And we keep having a debate about who's worst at it. And I think we're both probably equally bad. And there's actually very little that we've formally received in terms of guidance. So I'm a member of the doctor's Facebook group, and lots of people have said you need to pace. I got directed to this great big fat book about classic pacing for ME patients, which my cognition just can't take. So I just wanted to maybe invite a discussion from the rest of you about what you see pacing as, and practically, what is it that you would advise people to do in a nutshell? So whoever wants to go first.
I think the first thing to say is we all understand that word differently. So having worked with patients for such a long time with the concept of pacing, I probably mean a completely different thing when I say to people about pacing to what they understand and mean. So I think the first thing is always about having a discussion about what we interpret as pacing. Because to me, as an occupational therapist dealing with life skills every day, pacing is very much about a sustainable rhythm to life and about balance in life. So it's quite a complex concept. We use this term pacing every day in life, but actually it's a very complex concept. It involves speed. So there's concepts of rhythm and speed in there and slowing things down. I very much think about the difference between running a marathon as opposed to running to a sprint, that we need to pace ourselves to get through the kind of activities we want to be able to maintain. I think the other thing about pacing is it's very much about all of life. You can't just pace one thing. Everything in life uses energy. Talking to people, scrolling on your phone, physically walking up and down stairs. And I think one of the problems with pacing is that people very much see it as physical and about muscles. So it's about how to break activity down, then how to balance it, how we get a balance between the energy we have available and the actual activities that we're doing. So I can go into it more later, but that would be my simple start of the 10.
Well, I mean, it's interesting that you already said in your previous comments that you're both bad at it, which is interesting, isn't it? Because I think there is huge barriers to pacing. You don't want to pace. You want to get back to normal. You want to do all of these things. And the difficulty is that it's an invisible illness with invisible symptoms that don't happen until the next day. So it's very easy to think, I can just do one more thing. And then the second thing you said was, you've got the big book about it, but you're too fatigued to read it. And this is a real problem, that we're giving people information and they might read it, but then they're forgetting it. So, there are huge hurdles for people to overcome, and just having that reinforce what is pacing and how do we do it. It doesn't come naturally to most of us. And I think people just don't know where to start. It's a huge topic, isn't it?
I think Sue and Ruth have really hit on the critical issues at the root of pacing. But my other reflection here is that people with long COVID don't have a supportive social environment to pace. You don't just have a symptom, you have a social ill. Fatigue is associated with lazy or crazy, and nobody wants to feel like that. And nobody wants to support that. And so it really challenges the ability of people to pace. So I think there are key environmental pieces to pacing that also serve as important potential supports or potential barriers to a person's ability to do the things they need to do to take care of themselves and get the things done that they need to get done during the day, and not more than that.
This is a question for anyone really. Where do you start? Someone comes to you who's struggling, they're overdoing it, they're pemming themselves frequently. What's the first place you start in terms of helping them?
Well, certainly from my point of view, I think it is about understanding that pattern, because what you tend to see is this boom and crash pattern. As Ruth was saying, people want to do. So because these symptoms fluctuate and they're post-exertional, you will have better days where it seems like things are improving a little bit. And so your tendency is to just try and do too much. So often the starting point is with those. It's working out, what are we doing? Because on a bad day, you've very few choices. It's really about convalesce. You don't have to think about it a lot. There's only so much you can do on a bad day. choices come into play on good days. You know, on the days when we feel a bit better, we want to do all those normal everyday life things. So the starting point is often about going through with people, what do you actually do? How do you do it? So are we doing it all in one go? Like one lady will say to me, you know, I have to get everything done in the morning so I can rest all afternoon. So we're looking for patterns. And then what's really important is understanding how people rest, because it's very much about seesaw. It's all about trying to get homeostatic balance, you know, stay in that middle. And people are often very poor at resting because they've never really done it. You know, they were always very active, they went for a run, they did lots of things. They don't normally sit down and do nothing. So in order to pace, you've also got to learn how to understand the spaces between activity, that there needs to be space and what happens in that space and how is that space restorative. So it's a lot about asking questions about those, how it currently works, what you do, and how are we trying to balance things at the moment.
Yeah, I wanted to come in back to the last question a little bit about what is pacing, because actually I thought I understood pacing as a physiotherapist who has worked with people with fatiguing health conditions for many years, including HIV and cancer. But actually it wasn't until I developed long COVID that I realized I didn't understand the type of pacing I needed, because there might be different types of pacing that are described in the literature. And I think that we've already heard here that people describe and understand pacing in different ways. So what I learned, and has been mentioned, is pacing is the balance between activities and rest. And with that, it's understanding what are activities. So for me, I really didn't recognize that watching television was an activity. It was a cognitive activity that was using a lot of energy. And I thought that was rest. No. That was not rest. That was using a lot of energy at the time when I was experiencing my most profound disability. And I think the other thing that I learned was I thought I was managing my energy within a certain period, but I wasn't prepared for the delayed onset of symptoms. And that was therefore trying to figure out the ballpark of what was happening with my symptoms, what was happening over the days, the weeks, and further in relation to the activities. So with that question you asked there, Jez, about where to start, I think it's truly understanding your symptoms and what the patterns are with those symptoms in relation to the different activities that you're doing.
I completely agree. Ruth, did I see an emoticon flash up?
You did, yes. Yeah. I mean, where to start? One of the suggestions that I've offered to my patients, if you have the luxury to do it, is to start by stopping everything and seeing what your baseline is. And for some people, it's such a shock to have someone give them permission to stop everything, or as much as they possibly can, to strip back everything that's not essential. And that is, I think that is a real challenge for some people to say, really, I can't do anything. No, let's try and do nothing at all. To put it into context, so I had a youngster, a student, a couple of days ago, and they said, oh, I want to do this and I want to do that. There's a sports event at university and this and that. So we said, right, stop carrying your bag to university full of really heavy textbooks. Do not do the sports day for the end of year. Stop getting up and having a shower and doing your hair and doing everything else. Why don't you try doing that the night before? And within at least 3 or 4 days, already the relief of just feeling a little bit better for suddenly stopping and just changing everything, just taking a pencil case and a phone to university. And the relief for them of just getting a bit of rest. And then you can build this pacing back in. What can you do? Where are your limits? And they're not always in the same place, are they? They do vary. But I think you have to go back to doing very little to start with and then adding in and seeing how you get on.
You know, before I engage the how, I always back up and talk about the why. And we have precious few answers about why, but answering the why questions gets to the fundamental question a patient always has, which is what's happening to me? Why is this happening? And if you can address the why or start to address the why, then you get the buy-in to be able to address the how. And the why, the data we have regarding the why, actually gives us some very good information to be able to go on in order to develop a pacing program or an energy, I like to call it energy energy self-management program is what it is. We're doing energy system management. We're not just pacing. We're managing the function of a damaged aerobic energy system. So if we start with some of the data that we know about ME, that seems to index pretty well based on the post-exertional symptoms that we see with long COVID. Not to say that long COVID and ME are the exact same thing. Then I find that that's a really good place to start for patients. It really develops that buy-in, helps address the concern about the why is this happening, and it really helps us engage the how.
Thank you. I think that's really key, understanding the physiology behind it a little bit. Ruth, so just going back to the barriers to pacing, I mean, there's the understanding that, as Darren said, I can really relate to that. TV is a task. For me, I would never have thought of getting ready in the morning as activity. Whereas now, having a shower, getting dressed, having breakfast, and then having to lie down after that, it's really challenging mentally to accept that you're having to do that. So I really struggle with that. And then sometimes unexpected things do happen. So I had a day where I thought, okay, I've divided up my activity for the day. But then I got a call from the GP saying, you've got to bring your son in because some of his bloods are abnormal. So I just want to examine him. And that was bang in the middle of my rest period. So you don't have a choice, you've got to. And then I had the worst crash ever after that, because probably of the stress, the driving, being in the examination room, bringing him back, dealing with his anxiety. And I guess some of this is going to be unavoidable, but drawing on your experience, what barriers are you noticing that long COVID patients are facing, and how do you help them get around them?
Well, it's very difficult because some of them you can't, and I've had a small list of things, and one of them is life getting in the way. We have social life, we have family life, we've got financial obligations, and it's difficult, isn't it? Some people have to work, and unfortunately, therefore, that's all they can do, because then when they get home, they've used up their energy for the day. So there are a lot of personal obligations that we have with family. You've got to look after your children, you might have to look after your parents, you might have to go to work. That's life. It's very difficult to legislate for that, and the only thing that you can try and do is to offset it with an extra rest period, is to anticipate that you might have to take a family member to hospital, or if you've had a distressing phone call, that after that, therefore, you have to go and rest. You have to preempt it and think, well, unfortunately, I'm going to have to take my rest period. But actually, some of the other barriers to pacing are actually these emotional barriers. One of them is guilt. There are huge levels of guilt, because this is a new thing for people, and they look okay. You guys look all right, but you have to lie on the couch and say, I'm sorry, I can't, I'm exhausted. And that you hear what you're saying, and you see your family, your friends, whoever rushing around, and you're sitting there doing nothing, saying, I need to rest. The guilt is immense. I have one client whose wife is 8.5 months pregnant, and he says, I can't help you because I'm feeling tired. That's his words, not mine. And he really does feel incredibly guilty that he can't, but then he'll try, go up and upstairs, do the laundry, and then he realizes that he's no help to the rest of the day. So guilt is a big thing, and you do have to address that quite early on, because like you say, you've got to deal with the how and the why together. But if you don't get that understanding of what's happening inside, and so I'll often talk to people and explain, if you had a leg that was fractured in multiple places, and you had a huge plaster cast and a pair of crutches, and told you could not wait there and you ought to be resting and elevating your leg for 20 hours a day, you wouldn't question it, and nor would any of your friends or family, and you wouldn't feel guilty about it. And so it's trying to make them understand that something inside of you is not working properly and it is broken in some way, and that you are doing yourself and your family a favor by resting, by pacing, and by looking after yourself. You're more likely to progress quicker as a result. But the guilt is one of the biggest issues that we find. And the emotional side of things is accepting that you've got potentially a medium to long-term condition. It's hard for people to take on board.
I was just wondering, thank you, Ruth. I was just wondering if I could just jump back in and just give Todd a poke. He said you'd like to think about the why before the how, and I just wanted to just poke a little bit deeper on the how and where you start with that how, and how do you establish what somebody's energy envelope is?
Thanks for that question. So the main way to establish the energy envelope, at least in my practice, is to do it based on where we think ventilatory anaerobic threshold is, whether we've measured it on the second day of a cardiopulmonary exercise test, or we've calculated it. And I tend to use a lot of heart rate monitoring in my practice, because the heart rate monitor is like a crystal ball. That alert, that sound will go off if you set it to go off at the ventilatory anaerobic threshold. And it will tell you when you're doing an activity that is putting you above your ventilatory anaerobic threshold and therefore at risk for a post-exertional symptom exacerbation. And so then you can make some choices. And so at first, it's it's frustrating because the thing's going off all the time and you don't know what to do with it, besides just throw it out the window, which I've had people do, and that's not good for your heart rate monitor, and it's not great for you either. But I understand. And so that's where we start. And so basically then I ask the patient to just do a little journaling, write down when the thing's going off. When is that monitor going off the most? Maybe, as was pointed out earlier, it's going off at breakfast. Well, then we need to do something specific to the morning routine. Maybe it's going off later in the day. Maybe it's going off with position changes, which tells us something completely different. But yeah, I find that going back to that why really sets up the how nicely, and it gives us sort of an external barometer of exertion. And I think this is important because a lot of the discussion so far has been there's a lot of sort of psychological and emotional barriers to pacing. And I think this is a life-changing condition in long COVID. This is a life-changing condition in ME. So that totally makes sense. And one of the ways that you get around that barrier is having this external arbiter of your exertion. Hey, my heart rate monitor is going off. I really need to do something about this, or this consequence might happen. Can help mediate some of that conflict.
Yeah, absolutely. I mean, I've got one of these. I've got a Garmin watch, and I've set it to a certain figure. I was just curious, Todd, what calculation you use. I've gone with 220 minus age times 0.55, but I've seen different versions of it.
Yeah, a good question. And so the calculation is hard. I've seen everything from 220 minus age times 0.55 to times 0.7. I've seen, instead of using 220 minus age, using the gender corrected version of the formula, and then of course our preference is to try and measure it directly on the second day of a 2-day CPET. I mean, we can see the heart rate at ventilatory anaerobic threshold, and so then there's just no calculation necessary. I work with a group called the Workwell Foundation, which is just here in Central California, and has been doing a lot of research in education and advocacy in ME for a number of years. And the figure that they're using, I believe, is rest plus 15. So whatever your resting heart rate is, just add 15 beats to it. That tends to be a low end estimate. It's very conservative. I think 220 minus age times 0.55 is also pretty conservative. My sense is that 220 minus age times 0.7 is a little on the higher side, but so it's not a place I like to start. I'd rather start lower and then titrate activity up instead of start high. Completely nuke the credibility of the pacing program because it doesn't work, but yet the heart rate monitor is going off all the time. and have to titrate the activity back down lower. So the calculation is tricky. Direct measurement would be preferred, but of course the service isn't available to everyone.
So just to be clear to our viewers, so what we're trying to do here is avoid getting to that heart rate.
Yes.
And so we're setting the monitor to beep when we get to whatever figure we've calculated, and if that happens, we stop. Or do you set it even lower?
I tend to set lower, but I see Darren raising a hand, so I want to make sure that he has a chance to speak on it.
No, Todd, you're the expert. You should continue on this, and then I'll just give a lived experience on it.
I appreciate that. I'm not sure that if I don't have the lived experience, I'm the expert, but I guess I have some understanding. So yeah, my sense is to take a conservative approach here, because if you set the device so that it beeps, it's going to beep anyway, and it beeps at a level that's too high, so that you're exceeding your ventilatory anaerobic threshold under a margin, then you'll still have post-exertional symptom exacerbation, but your heart rate monitor will beep. And so I advocate rest plus 15, or as you've done, the 220 minus age times 0.55 also can work as a more conservative way to make sure that when that heart rate monitor beeps, that you're at a heart rate, you're at a level of exertion that is below ventilatory anaerobic threshold.
I think heart rate monitoring works. It is effective, but I've seen so many community groups get, okay, I'm going to be really unprofessional here and say people get their knickers in a twist about the numbers because people get fixated on it should be this, it should be that. I think the nuts and bolts of this is that it's a bit of an estimate as a guide, and it should be a practical guide that can help us understand our symptoms better, understand our thresholds better, with the intention of preventing post-exertional symptom exacerbation. So my experience was the calculations were there. They kind of gave me a ballpark figure. My heart rate was doing what it wanted to do, no matter what my activities were. So it wasn't necessarily all that useful, but I could definitely tell that every time I tried to go to work, my heart rate was going crazy because I have to go up and down stairs and there's no lift at my train station. So I knew stairs was an issue. So outside of traveling to and from work, I stopped using stairs, and surprise, surprise, I got a little bit better. So it was a way of finding out what was really making my heart rate go really high, whether there were ways of modifying my activities that were physical activities in terms of heart rate. But what I also noticed is that heart rate monitoring was not good for my cognitive activities, because I was still doing cognitive activities, still getting post-exertional symptom exacerbation, but my heart rate wasn't changing.
Yeah, I can identify with that. And actually, what I've learned also is that sometimes if you have one kind of exertion, so I've had a stressful time with one of the children, then I've got to make sure that I'm not getting to that range, and understand that maybe the trip to the shop that I've got planned for the afternoon can't go ahead. So it is an art. So I can see that Sue or Todd want to come in. Who's actually got the hand up now? Todd.
Thank you. So many buttons to manage. So thank you for that, for your experiences and for sharing those, because I couldn't agree more as a clinician. We're not necessarily trying to specifically predict where your VAT is for that ventilatory anaerobic threshold. We know that whatever calculation we're using is not strongly predictive of the number itself. We're trying to just help come in under that number so that people can make informed decisions about their lives. And I think you've hit on, Darren, not taking the stairs and how that changed things for you. And I think that's an important example of how you made an informed decision based on your heart rate monitor. And Asad, I know that, again, you may not have had a change in your heart rate monitor with some of the cognitive activities, the emotional work, but yet absolutely there are those triggers that could result. And so if you find that you're having post-exertional symptoms, even though your following your heart rate monitor, that can tell you something too. That just gives you another good piece of information for that puzzle.
Yeah, really to reinforce everything people were saying, that heart rate monitors are really useful for physical activity, but sometimes not as effective in other aspects of life. And I think it comes back to we use the motto, it's not just what you do, it's the way that you do it. So it's not just amounts of activity, it's what physiological state are you in when you do that activity? So you mentioned the phone call with the GP, suddenly we've got to go do something, suddenly there's a demand. So we're much more likely to go into a higher sympathetic arousal state, which is going to take more energy. We could do the same activity, the same kind of physical biomechanical processes, but at a lower heart rate and a calmer state. So you might go for a walk in the woods and it's all very calm and you're on your own and you have a lower heart rate compared to you dragging the kids to school and you're late, and they're getting at you and you've got to be there on time. So I think it's really important that we don't just look at energy in terms of movement of muscle or exertion, but we also take into account all the other body systems which might be adding to the guilt, the emotional demand, the cognitive demands. Sensory, we also haven't mentioned. A lot of sensory arousal means more sensory processing. So if it's noisy and there's lights and there's lots of people talking at the same time, it's harder to think. So it's really about making sure that pacing isn't just a formula. People understand how to adapt it to context, and that it's not a strict religion or a diet that you follow. It's about principles. And to me, it is all about that staying in the middle. You do a little bit, you pull it back. You try not to go past a level when you're going to give yourself post-exertional malaise.
Yeah, so I was just thinking, we're all medical professionals, and we're talking about quite complicated. We're talking about formulas. We're talking about heart rates. We're talking about judging our day, preempting things. We're used to dealing with exercise. We're used to talking to people who have fatigue. If this is completely new to you, plus you have brain fog, plus you've got a family or a job or a million things in front of you, this is it's complicated, it's difficult, it takes a degree of, organisation. I mean, I'm not desperately organised. To organise your day, when am I going to have my break, preempting some of the things that might happen, it's really complicated for people, and we do need to support people. And some people will need a real guidance of, yes, your heart rate monitor, 95, that's your lot. As soon as it goes above 95, then sit down. Some people are going to need those parameters to support them, to say, right, we're going to tell you what to do so you don't have to think about it. And for some people, as they learn to live, you've learned to live how am I going to deal with the crashes, with the phone calls, with having to take the stairs, or thinking you might want to go out for a drink. For a lot of people, let's not forget how complicated this is for some people who've got a lot of pressures to keep working or so on.
Yeah, I couldn't agree more. And the thing is that you have this challenge at the same time that you're impaired cognitively. So actually you're trying to do more with less, to do less. And it just, it spins you all over the place. A question for Sue, maybe, about what's the advice you give to people in terms of managing the fact that even whatever our limits are not necessarily constants or always the same. What we do on a good, we might be capable of more on a good day than we are on a bad day. How do we handle this shifting invisible limits that we've got that determines when we may or may not hit the wall?
Yeah, and I think it's incredibly difficult. As we're saying, this is complex stuff. Partly what we focus on first is about trying to stabilize. So I think people often are trying to do more. They feel ill, they want to get better, they've got all these demands on them. And we try and focus more on people trying to get stable first, trying to get less of the bad days, because with post-exertional malaise, obviously, if you do certain activities, you're triggering more symptoms on the following days. So the ways in which you want to reduce that is to work on the days you're doing those things. So it is variable, but I think once people can get principles to try and eradicate those worst days first, what are you doing that's triggering those? We tend to get to a more settled place. then we try and deal with problems as they come up. If you can get into a rhythm, into a pattern, it's then easier to deal with when an incident happens. Well, what do I do differently about, why was it that incident? What was it about that? But when everything's happening all at the same time, you don't know what's causing what, it's really difficult to differentiate that. So I think it is all about trying, I think like Ruth said about pulling back, it's that idea that try and get stable first, trying to eradicate those worst episodes where things are getting much worse. And that is all about the what are you doing on the days you can do more?
Yeah, I think anybody who's experienced this can identify with that. Darren, did you want to add something?
Yeah, I did actually. That's going to slightly echo what Sue was saying. So there's many of us in the kind of field of kind of like disability and rehabilitation that have been almost characterizing long COVID as multidimensional, episodic and unpredictable in nature. And this comes from a framework of episodic disability, which is that the disability or the impairments in daily life that people experience can go up and down. My experience of long COVID was very episodic and unpredictable. And so almost it feels like the goalposts are moving and it's episodic. It can be really difficult to prioritize and plan and pace. And so that point of stability is so important with the episodic nature of it, because if you can find the stability with the fluctuations that are happening, you can get a much better sense of actually what's a bigger flare versus just the episodes of my week.
Just to build on Sue and Darren's comment, that I think expectations are really important here, because people will come and see us with the understanding that we're OTs, we're PTs, and the picture on TV is of the athlete, right, getting ready to go back to sport, and so there's different prognostic expectations of folks who walk in the door. So I think it's really, I think what Sue and Darren have really hit on a very important topic, which is to make sure that people understand that we're trying to find stability, we're trying to find balance, we're trying to find a stable base of energy for someone to conduct their day. That's the first goal, and then to build from there. Because as we think less is more with energy management, and so that folks can have that stable base to start to improve. But again, it's that predictability piece that I think is critical.
Okay, so we've talked a bit about stabilization, and I kind of get what this means as a concept, but practically speaking, how do you stabilize someone? I appreciate that there's probably no straightforward answer here, but if that is the first step, how can people achieve this or try and achieve this? Because not everybody has access to people as skilled as yourselves. So if anybody's got any kind of advice around it, that would be really, really helpful.
I mean, I would say that it's not just about looking at activity and pacing when you come to stabilising. It's things like sleep patterns, eating, fluid, positions. Todd mentioned that earlier, the positions you're in, because sometimes we're lying down for very long periods and then suddenly we become upright and we try and do something and then we're back to lying down again. So there's all the issues around orthostatic intolerance. A lot of long COVID patients have got POTS type symptoms. So we need to address those underlying instabilities. Heart rate, we need to get that stable with breathing and controlling how we do exertion. So it's a lot about trying to get almost a biological clock, a stable process of sleep routine, eating patterns, fluid intake, and then where your activity fits within that. And also that after each bit of activity, we're almost resetting. So we're kind of getting the seesaw back in the middle. So we're able to activate our parasympathetic systems, relax, clear the brain, get rid of all that stuff we're dealing about, breathe, heart rate down. So stability is quite complex, and for many severe patients actually takes a very long time. We work people for years who really struggle to get stability, where there's other people who might find that once they make some changes, maybe their sleep is a primary issue, or they haven't been able to eat regularly, that actually getting control over one factor might unlock some of the other factors for them. So I think it's very much about that biological clock and seeing your whole life and recognizing where you're pushing too much. So a lot of people will say, well, I just keep going. It's that just word I think Ruth mentioned earlier. Well, I'll just do this and I just keep going. Pottering is a dangerous sport. People say, well, I potter. I do a little bit of this and a little bit of that. I'm realizing that's all constant motion. You know, so how can we get stable if we're doing, crash, and then we have to rest to go back again. So it's trying to do that more than do that.
Jez, did you have a...
I did. Ruth wants to add something, so I'll let Ruth add something first.
Yes, I agree that, you know, we do have to look at all the systems, because everything seems to be thrown into disarray. But I think one of the major factors is the emotional burden and the intellectual burden, that it's very easy to think, well, okay, I shouldn't go for a walk. But we do need to suggest you restrict your phone call times. You know, the time that you're talking to family members. I have some people, you know, even if it's nothing desperately complex, but just talking to a parent or a sibling, an hour is too long. So sometimes it's just reducing screen time. Unfortunately, the younger ones, it's hard for them to hear, but reducing television time. If you're watching something quite stimulating, I mean, you know, I don't know how you all watched the football yesterday, but you know, watching something like that, it's tiring. I mean, it's tiring for all of us, but it must be really, it's that mental exertion and the excitement. And I think those things can slip under the net more so than physical exertion.
You know, what you said, Ruth, there really, really resonated with me. And it actually felt really validating, because I, at the beginning of my illness, had a lot of people phoning to ask how I was, and you know, my siblings and parents would phone, and then I'd feel guilty about not having those detailed conversations with them. And I just find that I was actually getting nauseous looking at the screen. So then I said, right, I'm going to actually reduce the amount of time I'm speaking to you. But then I found that it got really frustrating, because it was just a quick hello and goodbye. And then the way I've got around that, and this might help some people, is I'll look at them on the video call, because that's what we all do these days. You know, maybe just say hello, yeah, you look all right there, fine. Now I'm just going to use the audio call. And I think that has massively reduced the burden of doing those phone calls. I'd like to get perspectives on rest here, because we've talked a lot about rest, and as somebody said at the beginning, you know, nobody's ever told us how to rest. We think rest is sitting down to do something, perhaps, or watching television. I find it very hard to just lie there doing nothing. And I think most people would identify with that. So what I might do then is I might listen to some meditation or do a bit of breath work. How would you recommend that people rest in a way that isn't boring? I can see Darren putting his hand up there. But contributions welcome from anyone.
I'm a recovering type A personality, and I have probably never rested before I had long COVID. So my Twitter profile used to say I was 100% busy and passionate, and I had to remove that when I got long COVID. And I think that it's very true that what's been said here a lot about guilt, I think also what comes into that is also shame and stigma. And that stigma is not only from other people, but also internalized stigma, because actually this comes from the stigma associated with disability as well. Many of us have fallen off the edge of a cliff when it comes to our impairments that we're experiencing, and it's come as a sudden shock. And so actually there's internalized stigma that we put upon ourselves as well, which is that I don't want to have a disability. And so a lot of us are also trying to get better quickly. And to us, a lot of that looks like move more. And so rest comes with shame, because maybe I'm not doing the right thing to get better. And actually, I think it's so important. We hear the message time and time again that stop, rest and pace works and is effective. If it wasn't for pacing, I wouldn't be sat here now feeling like how I do. It's been the most effective strategy. And I think we need to see rest as not a dirty word. Rest is an activity. And actually, it's part of the balancing with the other activities.
Thank you. That's really validating. Yeah.
Having done a little bit of research into this, as a society, we don't like rest. We've associated it over the years because of our whole industrialized nation as a laziness. Yeah, that actually resting. So many patients, when they come in and will go, oh, I can't rest, it's a waste of time, I need to be busy. We've kind of got all of these attitudes and beliefs that society's put in us, which then leads to all that sort of shame and guilt, because society is saying to us, well, rest is bad, you should always be productive and doing. But actually the human body wasn't built like that. We didn't work 24 hours a day and have lights and phones and things in the night when the body evolved. So it's helping people to understand that rest is a positive state, it's a restorative state. And that also it's not just about muscles, because a lot of people say to me, yeah, I rest all day because there's nothing else I can do. And when I say, well, what do you mean by that? It is the fact they're still doing things. Yeah, they're answering their emails, they're dealing with their social media, they're trying to sort out the kids' stuff for school tomorrow. Yeah, so if our brain is still functioning in a high alert mode, the body is still in a high alert mode. And that will still translate into heart rate and muscles and everything else. So I see rest as a skill that we all need to learn. I wish we were taught it in school, that it's a positive, restorative health. But you have to learn it if you've never done it before. So it's quite a challenge. So we do use things like apps, YouTube videos. People like different things. It's like diets. We all like different stuff. So some people like breathing exercises, some people love their heart rate monitor because they can just watch their heart rate go down. Other people need sound, other people need voices, some people need sensory stuff like a heavy blanket or, heat could help you relax. So it's really finding out what your relaxation diet is. And the other thing I say is rest is not about duration. You don't have to rest for hours because actually that posturally isn't as helpful. We need to keep changing positions at certain points. But it is about frequency, and it's about that switch, that we need to switch from sympathetic to parasympathetic as we go through the day. So we often talk about things like breathing breaks. Just put a pause on, breathe out, take a breath, let things go. And that could be in a meeting whilst you're on a Zoom call. It doesn't necessarily mean lie on your bed in a dark room with nothing going on. Sometimes that is what you need, and there are times when that's the only thing that's going to do, but that's not just the only form of rest. So I think I would argue for learning how to rest in creative ways and embracing it as a way of life.
I think that's a wonderful sentiment, and I completely agree that I have recently realized that I can take 30 seconds all over the place just to go, you know what, I'm just going to breathe in through my nose, I'm going to hold it for a couple of seconds, then I'm going to breathe out and take a really long breath out. And you spend 30 seconds doing that, and suddenly actually you're aware that you've changed your state of mind and you've changed what your body's doing, and you can kind of slip those in all over the place, even when you're driving. In the interests of everyone's attention spans and fatigue levels, I've decided to end part 1 here. So next up in part 2, the so controversial subject of graded exercise therapy, and just what our panel think of the biopsychosocial model for chronic illness. Till next time.